So I'm going to start with a quick history of vaccination and a bit of an introduction to some of the ethical principles that arise. And then I'll pass over to Hector, who will follow with a more specific discussion of the COVID ethical issues. And then we'll have our debate from Olivia and Bianca. So just to give you a bit of history, well, vaccinations are a truly remarkable invention, and they're responsible for saving more lives than any other medical product or procedure ever developed. And what's even more fascinating is that vaccinations were developed even before people understood the science behind how they worked. So Thucydides was the first person in 429 BC who observed that people who were infected with smallpox did not get reinfected. And from 900 AD, Chinese physicians have used a primitive form of vaccination called variolation, where powdered scabs are injected under the skin or into the nose. And then following Jenner's discovery of the technique using cowpox vesicles to inoculate, soon smallpox was eradicated around the world in 1980. Pasteur developed the use of live attenuated vaccines, which allowed for a stronger immunological response and a longer lasting immunity. And since then, vaccines have been developed for some of the most contagious and debilitating illnesses across the world. And some of these have even been eradicated due to vaccination. And the COVID vaccination response has demonstrated the ingenuity possible when we're faced with a worldwide disaster. And despite the seeming simplicity of injecting a vaccine, there have been important controversies and ethical issues that have arisen. And I'll give a brief introduction to these, and hopefully that'll be a catalyst for more reading and research around these topics. I'm just going to pause for a second there and exit because I need to admit a few people more to the meeting. Okay. All right, let's carry on. Fine. Okay, so one of the key ethical issues that arises when considering vaccination is the idea of mandatory vaccination. And in the US, smallpox vaccination was the first vaccine to be mandated in 1850, and having a vaccination was necessary to allow entry to school. And it was initially met with a lot of resistance, and that was especially from religious groups at the time. But since then, many states made vaccination mandatory, but now there's been a changing opposition, and the opposition now mainly comes from people who feel that their freedoms are impinged and their liberty to choose their own health has been taken away by mandatory vaccination. Now 20 states allow vaccine exemption for philosophical reasons, but the story is different in the UK. In the UK, it is a joint committee for vaccination and immunization that's responsible for making decisions about vaccination. And in the UK, there's no mandatory vaccination whatsoever. In Europe, certain countries will only allow entry to school if a child is vaccinated, or they might even fine parents for not vaccinating children. So there's a lot of difference even within our neighboring countries. And to talk a bit more detail about this, there was a paper written by Alberto Giubellini, who's a researcher on the ethics of vaccination. And he addresses a lot of the issues regarding mandated vaccination. So across Europe, recent drops in measles vaccination uptake has caused cases to triple. And it was found that it was much less likely for this to occur in countries such as Italy, where mandates were present, such as fines for people who did not vaccinate their children. In his paper, Giubellini argues that herd immunity that results from vaccination can be considered a public good. The definition of a public good is a good that is available to all members of a society and it benefits all members of the society. Herd immunity itself refers to the concept where if a sufficient proportion of a population is immune to an infectious disease, the spread of the disease is pretty much eradicated. So if herd immunity is considered a public good, one might argue that we have a duty to contribute towards it, even if we don't directly benefit from it. And we might also argue that the government has a duty to ensure that it is maintained. A key opposition to this comes from those who do not agree with government paternalism, arguing that having mandatory vaccination restricts the freedoms of the population. The least restrictive alternative is an important principle in public health ethics that aims to strike a balance between freedom and the need to protect the health of the population. So practically, this means finding a balance between which intervention is least restrictive while still allowing herd immunity to be achieved. But then this also raises the issue of how restrictiveness is defined. Is the least restrictive approach the one that saves the most lives, or is it the one that is least restrictive on liberty? And then you have the issue of fairness of a public good. Often public goods have an issue called the free rider problem, where people do not contribute to the public good because they feel that they can get the service for free without the need to contribute. So fairness of a public good would rely on people contributing, regardless of whether their contribution actually makes a difference. So perhaps following the least restrictive alternative principle, the best method would be to minimize the mandates for vaccination until there is a risk of a reduction in vaccine uptake. And if we're met with such a risk, it seems ethical that vaccines should be mandated for protection of the population, at least for a certain amount of time until the risk is reduced. Some ethicists have gone to the extreme and argued that not vaccinating a child is akin to giving them a bottle of bleach to carry around, and that bottle of bleach could at any moment spill and harm the child and all of those around him. I'll leave it up to you guys to make your own decisions about whether vaccine should be mandatory or not. And then to talk about a few other ethical issues that arise. So vaccine development is a cross-discipline process with experts from different industries, ranging from public health to pharmaceutical companies. And different stakeholder interests can lead to tensions in what they want the outcome of a trial to be. And in a clinical trial, control groups can sometimes be considered to be neglected. For example, where a vaccine could prevent them from contracting a life-threatening illness. And you might consider whether this is fair or not. Then to truly assess the effectivity of a vaccine, you have to test it on all the different population groups. And that includes testing on children. But then that raises all sorts of ethical issues around consent. Doing vaccine trials in poorer countries can also be seen as an unethical way of trialing a vaccine. Sometimes using vaccine trials in poorer countries is a guise to test the efficacy, where the poorer country may never be able to afford the vaccine at all. And while in the short term, a few people will stand to benefit from the treatment, the trial is essentially exploitative and the interests are often misplaced. Nonetheless, vaccination remains an important ethical issue, and COVID-19 has brought this to the forefront. I'll hand over now to Hector, who will expand on this.
Thanks, Parvesh, for a great introduction to the history of vaccinations and some overarching principles of vaccination ethics. I'd like to pick up where Parvesh left off, specifically applying some of these principles to COVID-19. First, I'd like to draw upon a paper written by Wibawa at the start of this year regarding the ethics of COVID-19 vaccine research. Wibawa makes it clear that at the forefront of all research ethics, whether that's for a vaccine or for a drug, is the safety of the research subjects. This is always a priority that applies to any research study. The COVID-19 vaccine trials are interesting specifically because of the time pressure involved in developing the vaccine. It's only a year since the pandemic really took off, and already we're distributing a vaccine. The average time taken for other vaccines to be developed is 15 years. And we can understand why there is such a time pressure, since vaccines are the most important public health measure to protect people from the virus. But the time pressure makes the trials unsafe, or potentially unsafe. And as well as the time pressure, there are other factors which pose challenges to safety. For example, we don't have any available animal models, and there's quite significant disagreement amongst experts regarding things like the duration of immunity if you have the vaccine or if you contract the virus itself. And there's also disagreement over the features of the virus which make a particular strain more dangerous than another. So Wabawa writes that, unfortunately, streamlining may have consequences for the traditional ethics of vaccine research and development, especially the long-held principles of beneficence and non-maleficence. And we've discussed already some features which may go against beneficence and non-maleficence because they pose a risk to the safety of the research subjects. Why else might this particular case and the streamlining involved, as in the speeding up of the process, pose a risk? One reason is that government ministers and heads of state might feel under pressure politically to increase funding for vaccines which are relatively underdeveloped. In addition, high expectations and high hopes for a solution to this pandemic might influence objective assessment of any vaccines that are under trial. And we have to ask whether doing something is always better than doing nothing at all. And is our judgment affected by emotional influences? And to demonstrate the point of how doing something might not always be better than doing nothing, we can use the analogy of DNA, of genetic therapy being used for patients who have an inherent illness in their DNA. So if you give a patient with such an illness genetic therapy, then yes, there are risks involved, but there is also the potential benefit, which is being cured of their disease. Whereas if you give a healthy research subject some genetic material like DNA, such as vaccines, then someone who was already healthy puts themselves at risk, while the benefits themselves are actually uncertain. So in that sense, we need to be sure that the vaccines we're using are properly developed, and that we don't fund them for the wrong reasons, such as our emotions and high expectations and hopes. What else is needed in an ethical vaccine trial? One thing is diversity, and this means diversity in the geographic areas in which the vaccine is trialed and the ethnicities of the research subjects. This not only ensures that inherent differences in immune responses are accounted for, but also accounts for the fact that different parts of the world have different strains of the virus circulating at any time. But like Parvesh mentioned, clinical trials which are run by institutions in wealthier countries and brought to poorer countries have their ethical issues, because we have to wonder whether the more vulnerable or poorer populations are being exploited for the sake of gathering scientific data. You might also argue that by doing this, an opportunity to have a vaccine or to have a treatment is provided when otherwise there wasn't one. But we have to admit that there are some unsettling features here. So how can we compensate for this increased vulnerability, or for the risk that the vulnerable person puts themselves at by taking part in the trial? One thing we can do, or one thing that a wealthier institution can do, is guarantee post-trial access to any vaccine that is developed. And in that way, you compensate for the risk that the more vulnerable research subjects put themselves in. This brings me to the concept of vaccine nationalism. And my source here is a paper written by Nicole Hassoun, also at the beginning of this year. Hassoun's main concern is that while wealthy countries in the EU, the UK, the USA, Canada, Japan, Australia can vaccinate the population between 2 and 8 times over, there are some poorer countries which will not have enough vaccines to vaccinate their populations for years. And the argument is that wealthy countries are not ethically justified in prioritizing their own populations, and that there's an element of luck involved in the place of birth of an individual, which does not provide someone with default rights, which are ethically significant enough to prioritize them when receiving the vaccine. Vaccine nationalism fails to respect basic human rights and the people who have them. This refers to the idea that the hoarding of vaccines by wealthy countries can be seen as a perpetuation of wealth inequalities that were already in place. What's more, it's not even smart to do this, Hassoun argues, because wealthier countries will benefit much more themselves if all countries were vaccinated, and not just their own populations. The converse argument is proposed by Ferguson and Kaplan in their paper entitled Love Thy Neighbour. Their argument is that as a member of a nation state, we should have a moral code dictating that we owe it to our co-citizens to act in their best interests, and that our obligations to members of the global community are weaker because the nature of our relationship with our co-citizens carries more moral weight due to things like physical proximity, and also the fact that our nation state, our government, provides benefits for us, which we should feel morally obligated to repay. But why are our obligations to members of the global community weaker than to our co-citizens? So why do we owe some moral gratitude to our own state and co-citizens? Is it because they were more involved in the development of our characters or our general quality of life? This line of argument fails quite quickly because we can all think of examples, say technological examples, examples in medical sciences, or even political examples such as the ending of wars, which were provided by countries that were not our own. And anyway, it's in every country's best interest to collaborate internationally and to ensure that every country has the correct amount of vaccines to vaccinate their own populations. Hasun writes that pandemics do not cross borders. And since the COVID-19 pandemic might continue indefinitely, we need to be strategic in the way that we fight it. And that is not vaccine nationalism. So the moral argument against vaccine nationalism is twofold. The first point is that the unit of measurement for moral significance is the individual, and that's irrespective of their country of origin. The second is that because the virus will be around for an uncertain period of time, there's no way to guarantee herd immunity in wealthy countries. And since the virus does not obey borders, global health is dependent upon a global approach to vaccine distribution. Thank you very much for listening to our introduction. And we'll now pass on to our speakers.
Thank you so much for that introduction, guys. That was a really, really good intro to vaccination ethics. And now I'm going to pass over to Olivia, who is our first speaker, and she is going to argue that the UK's government vaccine response was ethical.
Okay, great, thank you. Okay, so I'm going to talk about the ethical justifications for the UK government's vaccine response, arguing that it has been ethical. So this is the line of argument that I'm going to take. Firstly, we'll talk a bit about what it means to be ethical, and then look at exactly what the government has done. And then I'll try and dissect some of the underlying principles behind the response, and then we'll look at some criticisms of the UK government as well. So what does it mean to be ethical? Well, this is a question that has been debated among humans for millennia, so I don't think we'll get to the bottom of what is objectively morally good or bad today, but I do think it's worth thinking a bit about one definition of what it means to be ethical is to act in accordance with the moral expectations of the society in which you live. And I think this is quite a useful way of thinking about it when we look at what the UK government has tried to do with the vaccine response, because I think it's easier to think about it in terms of our own expectations and the ethical principles that we have as a society in the UK, and then look to see if the UK government's response is in alignment with these principles. And essentially, I'll argue that the government has used a mixture of different principles, largely utilitarian, egalitarian principles to in deciding what to do about the vaccines. So what has the government's response been? So these are the main aspects that I want to draw out, and we'll talk a bit about the prioritization and how they decided to do that, and then we'll look at how they delayed the second dose, and finally I'll talk a bit about the fact that it's non-mandatory and yeah, and free. So who has been prioritized for the vaccine? Well, I mean, we all know that elderly people, clinically vulnerable people, have been prioritized. And what are the underlying principles for doing so? Well, the JCVI, which Parvesh mentioned earlier, who are the people who decide these things for the government, they say themselves that they justify it based off of the principle of trying to maximize the number of lives that they're saving, as well as preserving the NHS and social systems, social care services. So this is, in my own interpretation, a very utilitarian approach, because they're trying to maximize the benefit for the greatest number of people for the whole population. But on top of this, it also has elements of trying to like be more equitable as well, because they're not treating everyone the same. They're trying to prioritize the least advantaged in our society. So this is like a Rawlsian principle of distributive justice that doesn't try to treat everyone equally, but rather level the playing field, because the government has recognized that we're not all in the same position, and some people are at much greater risk of dying. So specifically with COVID-19, obviously it's the elderly who are most likely to die. So I would say those are two of the main principles behind this aspect of the prioritization. But there are some other things that I'd like to draw out as well. So it kind of goes without saying, but saving lives is putting a lot of value on life, and I think that's fair. It's fair to say that in our society we think that life is intrinsically valuable, and this is a sort of inheritance of our Christian past, but also it's a widely held belief all over the world. And also within the age cohorts and like clinically vulnerable cohorts, what's quite interesting about this approach is that it's quite egalitarian. So the best way to explain this is when to think about the Queen, because in this, when the vaccine started being rolled out, the Queen was not the first person in the country to get the vaccine. And what this shows is that, they're trying to come across as, we are trying to appear egalitarian and not privilege certain people within the cohorts based off of wealth or perceived societal value. And this is very different when you look at other countries across the world at the moment. And I'm sure many of you have seen photographs of presidents and prime ministers being the first people in their respective countries to get the vaccine. So I do think this is reflective of a specific aspect of our own society's expectations and ethical principles. So, but having said that, in the prioritization, we've basically done exactly the same as most other countries in the West, at least. So Canada, Germany, they basically have exactly the same prioritization scheme as we do. But what would the alternatives be if we hadn't chosen to do this sort of maximizing, saving the most number of lives utilitarian approach? Well, there are other ways of determining, cost effectiveness and utility of resource allocation. So a common way that this is done is to look at the years of life saved. And typically this would be different from just saving maximum lives, because years of life would value young people who have more years left to live. However, with COVID-19, of course, again, if it doesn't target young people and old people equally, so if we gave the vaccine to young people first, it would be it would certainly reduce morbidity among young people, but it wouldn't reduce mortality by nearly as much as it would if you prioritize elderly people. So this is an argument put forth by Giubellini et al., who say that ultimately, if you look at lives saved or years of life saved, ultimately the conclusion would still be the same, that you need to start with elderly people first. In terms of QALYs, so these are quality adjusted life years. And this is a commonly used method in the UK, in the NHS, for determining resource allocation. Essentially, what you do is you calculate cost effectiveness by timesing 1 year of life by the kind of quality of that life on a scale of 0 to 1. And that comes out with a sort of number that you then use to do your calculations and compare different people's lives and how worth it is to save them or give them treatment. And in the case of COVID-19, again, I think if you look at what that would mean for the vaccine distribution, well, for example, if you take people with dementia, they're considered to have a less good quality of life than a healthy person. And 70% of the people in care homes have dementia. So if we went down the QALY route, you can quickly see why this would probably come across as unfair to a lot of people in society who, because those people would not be prioritized for vaccination. And then there are some other things we could look at, like essential workers, disabled, and ethnic minorities. These groups of people, certainly there are strong reasons for why it would be good to prioritize them. And in the last week or so, I think we've seen how the people who are disabled are being given more access to vaccines, because the definition of who is considered clinically vulnerable is being expanded. But more could still be done, because I think disabled people are 6 times more likely to die than healthy people or like non-disabled people. So in terms of equity, it makes sense to try and privilege them more. And the same goes for BAME communities. Obviously, we now know that they have suffered disproportionately during this pandemic, and again, it makes sense to try and give them prioritize their vaccinations. However, what I would say in defense of the government is that at the beginning of the vaccine rollout, it was a very time pressured situation, and looking at age is a very objective and quick way that is included in everyone's medical records. It's a quick way of getting through groups. And so I think at the beginning of the vaccine rollout, it was probably justified to go down this route. And now that now that we're getting through everyone, it's time to be more nuanced in the approach. So ultimately, not everything that the government has done has been perfect, but I think largely, I think it's been ethically justified. Okay, so if we look now at delaying the second dose, this is a very controversial thing that the UK government has done. As we all know, we're the only country in the world who's decided to postpone the second dose for up to 12 weeks. But if you look again at the JCVI, their justification for doing so has again been to save as many lives as possible and to prevent the NHS and hospitals from being overwhelmed. And again, I think this is a reasonable justification for it from an ethical point of view, especially at least because they knew that the AstraZeneca vaccine could be postponed for 12 weeks. Yes, with the Pfizer vaccine, it has been a gamble, and I agree that it is quite, there are issues with this, but I think so far it looks like the vaccination scheme is reducing the spread of the disease. So it is, I don't know, I think time will tell, but I don't think we can completely condemn what they've done so far quite just yet. But there were other things that the government didn't know whether it would work. For example, the efficacy of AstraZeneca. However, we now know that it does produce lots of antibodies in the elderly. How long immunity would last, we still don't know. And as for the mutations, I don't think there's anything they could have done differently to anticipate the South Africa variant, for example, in terms of changing the vaccine rollout. I think it's still, important that they try to just get as many people vaccinated as possible. So, but yeah, there are lots of issues around all of these things, and I think it's a very great area, but I think they're doing about as well as they could be given the circumstances. So in terms of the vaccine being mandatory, we've already heard about this today, so I won't talk about it for too long, but I do think it raises a lot of interesting questions about autonomy. And I can see why a lot of people would be against the idea of making it mandatory for that reason. A lot of people are, I think it makes sense that people are suspicious of the idea of the state trying to force them to get a vaccine, especially because at the moment the reason why people are not taking the vaccine up as readily is basically because they're afraid of what the vaccines can do to them. There's a lot of fake news around at the moment, which we all know about, and I think lots of people have written about this, and I think the argument that we should try and persuade people and treat them as equals, as autonomous individuals, is a very convincing one for me, because I think it's sort of in keeping with the ideas that we've been talking about earlier of like equality, and I think autonomy is one of the 4 pillars of the ethics for Methix. So yeah, that's all I have to say about that. And finally, with regard to vaccine hoarding, again, this is a very controversial area, and we also heard about this earlier. I think with regards to the UK's response, however, I do think it would be unfair to say that they are in danger of hoarding quite yet, considering how much they have invested already in COVAX. I think there is a recognition that they are morally obligated to help out the people in other parts of the world who haven't yet been able to access the vaccine. But also, the government's first moral duty is to protect the electorate and taxpayers who are funding the vaccine rollout in this country. And I would argue, and I think it would be hard for the government to justify giving away too many of the vaccines before they've achieved that. So it's definitely a great area, but I think, that's basically what I just said. So, I think it's I can see why people are worried about this, and I just think it's we still have yet to see exactly how it's going to pan out. So thank you very much. That brings us to the end of what I wanted to say. with regards to the ethical approach of the UK government. And here's a reminder of the key points that I've made. And finally, I'd just like to summarize by saying there's a mixture of ethical justifications for what the UK government has done, which I would argue are largely in keeping with the expectations of the UK population. And it hasn't been perfect, but it has been largely ethical. So thank you.
Thank you so much, Olivia. That was such an informative and really, really well-researched presentation. Now I'm going to hand over to Bianca, who's going to argue the other side, and so the vaccine response was not ethical.
Thank you, and thank you so much, Olivia, for that. Really insightful discussion on the ethical aspects. As Lauren said, I'm going to be arguing the opposite, that the UK's response has been more unethical than ethical. So if you just go to the next slide, sorry. So we're kind of going to be looking at this from the principles of ethics kind of perspective. So you guys know about autonomy, beneficence, non-maleficence, and justice. So if we begin with beneficence, the sort of immediate striking decision to me that came under this was the radical change from the advised double dose to now a single dose of vaccine. Pfizer has repeatedly advised against this, and even preliminary studies suggest that the 52% efficacy at day 12 may not last. Now, you might argue that it's being trialed in Russia, for example, by the Sputnik-like light IV vaccine. The difference is those are trials, those regimes are being tested, and then if they're successful, then they'll be implemented, not ignoring scientific rationale and the scientific method entirely. The so-called new Pfizer study, which was released recently, supports some of the claims which has been made by the UK's vaccination committee and the JCVI, as has been mentioned before. They claim that the first dose will provide you with 90% efficacy. But that kind of claim is just misleading and undermines the trust that the public place in us and in public health. If you look into the study, what it actually does is it uses data from double dose patients and it interpolates that data between day 15 and day 21. But the thing is, if you're looking at the effect a single dose will have, using data from double dose patients cannot sort of indicate what an equivalent response would be like. Similarly, if you look into Oxford AstraZeneca study, they claim an efficacy of 64.1%, but they also say that's for at least one dose, i.e. not all of their patients underwent the just one dose regime. And it doesn't really equate to the massive gamble that an ineffective single dose could have, and that could potentially lead to hundreds, if not thousands of lives being lost. And we've seen this before actually happen. In terms of the MMR vaccine, there's a 10 times disparity. So if you take one dose, then 40% of people are left unprotected. Whereas if you take two doses, then only 4% of people are left unprotected. Likewise, some of the new trials about mixing vaccines have raised a lot of concerns. So in terms of mixing vaccines, this would be, say, having Pfizer the first time and then, say, Oxford AstraZeneca the second time. They've been disapproved by NHS England, and the NHS England said it was wasting resources, but also the Public Health England have warned against it. You might argue that if they both induce an immune response, then it should be okay, right? They'll both produce antibodies. But the risk is quite big if they don't produce a sufficient immune response. There's a place called Samoa, and they had this measles epidemic a couple of years ago, and the epidemic resulted just as a result of a sort of local mistake where there was miscalculated mixing in terms of doses. And 2 deaths in that scenario was punishment enough, but the fact is that had much longer term consequences and implications. So in nearby Nauru, for example, the vaccine compliance was about 99%, and that's what it was previously in Samoa as well. But now it's decreased to 31%. And it had really long-term consequences for reduced vaccine uptake in future epidemics and pandemics. Another argument some people might have that, oh, they've mixed vaccines before, like for Ebola and hepatitis B. But the difference was, in the case of the latter especially, they had time on their side and we don't. And as someone that has been cited a lot recently, Dr. Simon Clark has emphasized, it is a massive gamble if it doesn't work. If the immunity is different, it poses very serious medical legal consequences. And then who is to blame for that? And it's simply not fair that the population will have to suffer for the government's mistakes. This actually brings us very nicely to justice in terms of what is actually fair for the population at large. So yes, the UK have invested billions into their own schemes, and we can't argue against that. But the World Health Organization have criticized the UK for hoarding surplus numbers of vaccines, which is unfair on the developing world where COVID-19 mortality has been far worse. For example, 16% of the world's population, that is the population within the developed world, mostly, have taken 60% of the world's share of COVID vaccinations, which is hardly fair. You might argue, for example, that the UK have invested millions into COVAX, yet the government's continued opposition to patenting free vaccines completely undermines this effort, in which that opposition they have maintained during the pandemic. And also, it's predicted, despite the efforts of COVAX, the majority of the developing world will not be able to access the vaccine by 2024. And who knows how many lives will have to be lost until then. Even if we take Europe as a whole, instead of just the UK, for example, they've contributed less than half to the US than the US has to COVAX, even though their GDPs in total are actually roughly similar. Some people might argue that the UK has an aging country, and that's why we need to take more of the vaccines for ourselves. But that doesn't really apply anymore, because so does a large population of the proportion of the developing world. And actually, if we stratify it by like population size, the developing world has double the number of people aged over 60 than the developed world does. Which means it doesn't really make sense that the UK have ordered enough vaccine for 3.7 jabs per person, yet are unable to administer 2 doses, and in doing so have prevented the rest of the world that need it from taking their share. Even when we consider internal distribution, there have been issues. We've all heard about the issues Brexit has had with interfering with supply. And as Olivia mentioned, in terms of the vaccination distribution scheme, healthcare professionals in the UK were second priority, despite being at the front line. Now, lots of other countries, including in the developed and the developing world, have actually put healthcare professionals first. You could argue that it's not relevant now because the majority of the front line have been vaccinated, but other essential workers are still being ignored. In fact, 1 in 3 police officers have been threatened to be infected by the public during this national lockdown. If other countries like India, for example, can take this into account, why is the JCVI refusing the pleas of so many unions to give essential workers the vaccine they need to get back to work and look after society? Why are we not willing to protect the people that have been our backbone during the pandemic, especially when Public Health England, despite not being in the first 4 priority groups, 100 of their staff managed to get the vaccine, which would be illegal. So what is the point in even having this entire vaccination strategy in place if it's not going to be properly implemented or enforced? The lack of transparency has been made even worse because the JCVI has been ignoring repeated recommendations and advice from healthcare professionals to target BAME areas, for example. If we look at the counties within the UK, those that have had the maximum vaccine distribution, taking into account their proportions of BAME population, for example, have had higher proportions of white residents. And that is mirrored in other areas in the developed world, like the US, for example. But we really need to be targeting the BAME areas, where individuals are at high risk of COVID, and access to healthcare areas like GPs, for example, local healthcare services, is just substantially less. If countries like Canada can take this into account, then why can't we? In fact, a consideration of marginalized communities is actually in step 2 of their 3-step vaccination scheme. Even if we do manage to improve the rate at which we're vaccinating at, it is possible for us to then target these BAME areas and ensure more people are getting vaccinated. But this doesn't really fit into the wider scheme of actually reducing the number of infections if other rules are not going to be followed. For example, Professor John Bell has emphasized this at Oxford, that it's just going to be made worse if you have the UK's vaccination policy, but then people are going to receive single doses and then just decide not to comply with rules even further. It's not plausible for the government to expect rule following out of pure altruism following a vaccine dose. Cases will continue to rise in some cases, in some areas, and people will die. So a good vaccination strategy ought to be planned well in advance, alongside consistent messaging and rules on social distancing to minimize cases, not haphazard changes like our government every few weeks. Putting other people at risk is not the right of any individual in this country. This makes autonomy slightly difficult in a pandemic. If we could go over to the next slide, that'd be great. Sorry. Yeah, so max vaccination strategies, for example, as has been mentioned before, ideally, if you want to maximize uptake, mandatory vaccination is one possible route, especially in the UK if we consider the levels of vaccine hesitancy, and they're one of the main barriers to distribution. But if we look at the actual data about vaccine hesitancy, less than 1.5% of those refusing the COVID-19 vaccine are actually anti-vax in general. People are worried about issues like safety and issues like commercial profiteering. Again, emphasizing where information campaigns need to be targeting the issues that people are worried about. For example, only 49% of British Black adults are for the vaccine. Again, emphasizing where we are missing targeting the communities that need it. After all, we know that autonomy underlies the principle of informed consent. But how can individuals be expected to make an autonomous decision if they're not sufficiently informed about it? The misinformation about the COVID-19 vaccine is so widespread. And while social media is gaining a lot of attention, especially in the media, the emphasis on local communities really needs to be encouraged. For example, in one community in England, a large proportion of the community refused their vaccine because their local pastor had advised against it. We need to be working with local communities, like Israel, for example, who have been working with local rabbis in collaboration with ministries and the government. Yes, admittingly, schemes are being put in place now, but in some areas, it's just too little too late. Why did the JCVI not address these issues when healthcare professionals did raise them months in advance? Instead of stockpiling and gloating about vaccine success, we need honesty and transparency to increase uptake and divert the billions we're spending on vaccinations to the areas that need it the most. There is more than enough supply. So why are some people still at risk of harm? That brings us on to non-maleficence. Non-maleficence in this case links very much to working in the patient's best interests. So really links to beneficence, but essentially lies on the principle of do no harm. I've kind of touched on the poor organization already, but the fact that the government are ignoring their own plans and modeling and changing their decisions so rapidly is not only unprofessional, but it undermines the value of accurate scientific research. You might argue that UK are the third highest in vaccinations in the world, but look at Israel, where vaccine hesitancy rates are much lower and local communities are actively being involved in planning and strategy. Not only is this poor organization harming the public, but also the healthcare professionals. While we might be funding billions for COVID vaccinations, resources are being diverted away from essential services. And some trusts have actually been told to reduce their essential work that is already under significant strain in order to vaccinate others. Again, we have that issue where resources are not being diverted appropriately. Like let's take a single GP surgery, for example. They'll get funded £10 per jab. That's compared to the £22 per jab in Israel. We need to protect the healthcare professionals that have been protecting us during this pandemic, just as much as we vow to do no harm to our patients. It's just not fair. It's not fair that the healthcare professionals who have been toiling away, the public who have been searching for answers, and those who are at risk are being put at harm. If this single dose regime proves to be ineffective, we may have lost months of time, but more importantly, thousands of lives. If you can move on to the next slide. Cool. So as you guys know, that the case numbers have been decreasing, and while that is great, death numbers are also decreasing. They're still higher than the peak of the first wave. Looking at some of the public health literature at the moment, some researchers argue, based on million grounds, which use the principle of non-maleficence, that mandatory vaccination in this case could be justified, because simply put, we cannot reach herd immunity in this case, despite the ramping up of vaccinations. We've got over 100,000 deaths, and we are at continued risk of further harm. Every minute delayed is another COVID admission. And instead of mandatory vaccination, a real ethical scheme will require radical changes to the UK's information, distribution, and management strategy. There has been a lot of progress, and like all of the aspects that we mentioned so far, there are lots of ethical things, and particularly the distribution order, like targeting vulnerable adults and the elderly, for example, that has been done really well. But the current scheme just doesn't have sufficient public trust, and money isn't being diverted to where it's needed. We really want to minimize the pressure on our healthcare services, protect the vulnerable and the elderly, and distribute the vaccine fairly and safely. But to do so, we need our government to be transparent with us. The UK has succeeded on many parts, and as you can see, the vaccine sort of uptake has increased very much recently in the graph on the sort of bottom, and lots of the doses have actually been administered. But there is a very long way to go before truly ethical distribution practice is achieved. Thank you, that's all I have.
Okay, thank you so much, Bianca. That was amazing as well. Such a great presentation, so well researched and really well argued. So now basically we're going to open up the discussion to the floor, so anyone can answer. You can put your hand up, you can just speak, you can unmute yourself, and you can also put stuff into the chat. Just a really quick reminder before we get to the discussion. The event polls are in the chat, so just click on the links and fill out the forms. Like they'll only take like 2 seconds, and if you want to sign up to be part of the debate, again, all you have to do is just basically put in your name and email. And then, yeah, the post-event feedback also would be great. So now we're going to start the discussion. So if anyone has anything to say, any questions for either our speakers or just a general comment, please feel free to share. Yeah, go for it.